and welcome to Population Health Plug-in, a show highlighting current public health issues in our community and topics of interest to students here at the UAB School of Public Health. My name is Tessa Graham, and today we're going to focus on suicide and suicide prevention with Suicide Prevention Awareness Month coming up in September. Suicide is a very serious issue that touches too many individuals' lives every year. Thankfully, we have a great community and other organizations working to bring awareness to this issue and help keep the public informed here in Alabama. Before you listen to our podcast, please remember that discussing suicide and suicide prevention can be sensitive topics, so ensure a safe and supportive environment for yourself, and please seek resources if you need assistance. 988 is the Suicide and Crisis Lifeline. Think about it like 911, but for a mental health emergency. Joining us today to talk more about Suicide Prevention Awareness Month is Dr. Angela Sullivan. Dr. Angela Sullivan has been involved in suicide prevention since 2002. She holds a PhD in health education and health promotion, where she focuses on suicide prevention through intervention development and evaluation. Dr. Sullivan is currently serving a one-year term as the president of the Alabama Suicide Prevention and Resources Coalition's Board of Directors, ASPARC, and as an advisory committee member for the National Suicide Prevention Resource Center, State and Territorial Advisory Committee. Thank you for joining us, Dr. Sullivan, and we appreciate your willingness to discuss this issue with us.
Absolutely, Tessa. Thanks for inviting me.
Awesome. So we'll get right into it. So you do a lot of great work here at the School of Public Health. Could you tell us a little bit more about the other work you do with ASPARC? What are some of their common goals and initiatives?
Absolutely. I've been volunteering with the Alabama Suicide Prevention and Resources Coalition, ASPARC, since about 2016. I've been their treasurer, their secretary, and now, as you mentioned, the president. So for the first few years, I was one of the primary QPR, which stands for Question, Persuade, Refer, gatekeeper trainers. And since then, I've worked more toward coaching new trainers to offer this very important and free training throughout the state. ASPARC as a whole has a couple of goals. One of them is to work to lower the rate of suicide in our state, to educate the community on suicide prevention, and to help reduce stigma around mental health. And of course, promote mental health awareness and provide the community with resources. So some of the activities or initiatives that help with these goals are hosting these free QPR trainings. We also coordinate an annual statewide suicide prevention conference. We were putting this on just ourselves, but actually this year, and this conference will be in September, we've joined forces with Troy University and the Alabama Department of Mental Health. Yeah, so we'll be offering this together, which I'm really excited about. We were having roughly 2 to 3 statewide suicide prevention conferences a year. Oh, wow. And we realized, there's not a lot of resources in mental health. That's a lot to kind of spread around.
Unfortunately.
So I know. So it's like, we're all volunteers. Let's work together. And so I'm very excited
pool
about
those efforts.
Yes.
Awesome.
And then finally, another initiative that is really important, but more of a behind the scenes is ASPARC's website hosts what we just refer to as a resource directory. And so this is information for the layperson, for clinicians, for school resources, school counselors, really anything you can think of. And so this is on ASPARC's website, and it's been built by help of our community partners. So oftentimes we'll host a QPR training for any number of community groups, community members, or our individual trainings where anybody can join, and people will follow up with us and say, oh, you mentioned this, we have this great resource, I noticed it wasn't on your website. So we've been working with folks across the state, but really whoever's been willing to help out
building that network
to build that network. And so I encourage anyone to go check that out and let us know if there's something missing. We'll be happy to add it.
Yeah, awesome. Thank you for that introduction to ASPARC. I know that'll be very, very, very important for this conversation. So we know that suicidal thoughts and suicide, much like any mental health condition, they can affect anybody, regardless of age, gender, background, income, anything, any socioeconomic factor. Can you tell us more about the current impact of suicide in Alabama?
Absolutely. And I appreciate the way you asked that question, because mental health doesn't care how much money you make. It doesn't care. There are groups who are affected by this, and I know we'll touch on that a little bit later. But according to the American Foundation for Suicide Prevention, AFSP, a couple of fast facts about Alabama are that suicide is actually the 13th leading cause of death in Alabama, and that actually dropped. It was 9 or 10, but since COVID and COVID-related deaths, it's actually kind of appearing as if the rates have slowed down, but it hasn't. Suicide is actually the third leading cause of death for ages 10 to 24 and 25 to 34. Alabama is ranked 25th for the number of suicide deaths. However, if you look at our rate per 100,000, our rate is 15.9 and the national rate is 13.4. And so Alabama has had higher than the national rates of suicide deaths and actually has since the 1980s.
Oh, wow.
Yeah.
Interesting. Yeah, I wouldn't have expected that for Alabama. So leading up to that, a common misconception I had, what are some other common misconceptions or stigmas surrounding suicide and mental health, and how can we as public health workers, address and dispel those misconceptions and those stigmas?
Yeah, so I appreciate this question too, because part of the QPR training that I've mentioned several times is actually addressing common myths. And I'll tell you, me personally, others who've been involved with ASPARC for years, I believed several of these myths as well. I mean, there's no malintent. It's just misconceptions out there, just like you said. So I would argue that the number one misconception about suicide prevention is that if you ask someone about it, if you're worried about someone and ask them if they're in crisis, you might give them the idea, plant that seed in their head to act on potential suicidal thoughts. But the opposite's actually true. So if you ask someone about a potential crisis, it opens up communication, lets them know that someone cares, and then it's an avenue to share resources.
It is. That's true.
Yeah. And so kind of following up on that to address stigma, we could go really big picture. We could strengthen and enforce laws regarding discrimination against those who have mental illness. We could, and I'll say continue education. So multimedia education, things like QPR training, things like what you've invited us to do here today to help try to convince people that mental illness and suicidal behavior, these are understandable responses to maybe it's a history of extremely stressful life circumstances, maybe a slew of other reasons, but I hate to use the word normal, abnormal, things like that, but it is normal. It is normal to feel that way sometimes. I think other ways that we can address stigma are testimonies by entertainers, other, prominent people, but also healthcare workers. Your average person also struggles with mental health. And so I think just talking about it as a community as well and within our families would help with stigma.
Yeah, absolutely. So I'm hearing a lot of awareness.
Yes.
Raising that awareness can do a lot for an issue like this. So something like Suicide Prevention Awareness Month in September, that can do a lot in that area, I'm assuming. So how else does raising awareness contribute to tackling this issue?
Yeah, and I think if we take the time every September, so there's folks like me who work in this area. This is on my mind every day. There's folks who struggle in this area. It's on their mind every day. But for folks who don't work in this, maybe you don't have a close friend or family member, even that annual, September is Suicide Prevention Awareness Month, I think taking the time to pause and refocus on the importance of mental health as a part of, holistic individual health and community health is important to do, especially, again, for people who don't engage with this topic outside of the occasional, out of the darkness walk or a training scheduled. It's great, though. I think this is a time to be sure that individuals are trained in things like mental health first aid, QPR gatekeeper training, or any other training that might be available.
Gotcha. Well, until those individuals can get into those trainings and build up those resources on their own so they can bring awareness, what are some of the key risk factors and warning signs for others to be aware of? And how can individuals, families, or even other community members recognize and help respond to these signs?
Yeah, so I'll answer this in two ways. So again, you mentioned this earlier, and I want to reemphasize anyone could face a suicidal crisis, but there are higher risk groups. And so those groups include men, just Men,
Wow.
period. Yeah. So women actually attempt 4 times as often. Men tend to select deadlier means
Interesting.
when they attempt. Yeah. So simply being a man. Those who are middle age, so 45 to 50, American Indian, Alaskan Natives, people who are LGBTQIA+, active duty military, veterans, National Guard, youth and young adults, right? So another very broad category.
Mm-hmm.
Anyone who has lost someone to suicide, suicide attempt survivors, disaster survivors, and then anyone with a serious physical or mental health diagnosis. And so those are the high-risk groups. When it comes to clues, warning signs, there are direct verbal clues. So someone saying, I'm thinking about killing myself, or any version of that. There are indirect verbal clues, so it may sound like, oh, I won't be around much longer, or pretty soon you won't have to worry about me. You really don't need any more clues when you've got these verbals coming at you. But there are behavioral and situational clues that include things like suddenly rehoming a pet, or giving away prized possessions. And it's at that point when you want to consider the perspective of the person. So maybe to a 13-year-old, a prized possession is their Xbox. Maybe to someone who's 84 years old, their prized possession is, collectibles that they've had their entire life. And again, to indicating directly or indirectly that they're considering suicide. These are all warning signs. Any major life event could also be a situational clue. So there's a whole lot of factors that go into it, but I'll say trust your gut. If you feel like a friend or family member or coworker, something's off, and you start to have, I won't even say red flags, if there are orange flags going up, ask them about it. Yeah, any flags. Ask them about it. Trust your gut on that. But there are specific warning signs, and we do talk about that in QPR training, and mental health first aid covers those warning signs in great detail as well.
Yeah, so definitely something for especially anybody with any interest in this area to look into.
Absolutely.
Gotcha. So one of those key ways that everybody knows we communicate now and interact is social media. So could you discuss the impact of social media and the internet on suicide rates and prevention efforts, and how can we ensure that those are safe spaces for individuals that are struggling?
Yeah, and I'll say it's difficult because these things are evolving so rapidly. But
That's true.
Honestly, and I'm a glasses half full type of person, so I will say I am pleased with the attention and efforts that social media sites have for reporting and for safe communication. However, there is still a lot of work to be done in this area, and I think really one way that we can practice safety as a community in a virtual space is to practice safety when we're in person, when we're in a live event. And so it's okay to not know or to not understand best practices for talking about mental health. These things aren't intuitive. But if there's been, say, a suicide death in the community, knowing how to report on that death. So there's media training, knowing how to, what do you do if there's, say, a suicide loss in a high school? What are the best practices? We've got these resources on the ASPARC website. And so
how do you connect those people with those resources?
And so connecting folks with those resources, but then too understanding that, again, I really don't think that these things are necessarily intuitive. And so taking the time to learn about it, taking the time to make sure you're safe, your partner's, safely approaching social media, and kids as well. I mean, I think that the majority of social media users are really pretty young these days. And so not monitoring, hall monitor, but also talking about specifics. When these things come up in the news, when there's something on that has happened in social media regarding mental health, taking the time to talk to your kids about it, I think is also important. But the onus does also fall on, Meta and the owners of these social media sites to make sure that reporting and safety is a number one priority.
Overall, that's on them for sure. So having those conversations, maybe parents having them with those children or something like that, but destigmatizing those conversations to help keep those channels of communication open. Could you kind of discuss a little bit more of the importance on that and how we can keep those open dialogues to contribute to reducing that shame and stigma and misconceptions?
Absolutely. Talking about it more, there's the regular people, the celebrities, the people in leadership and power, and also healthcare and mental health workers. So I'll share a personal story on this that's, a story within a story, I guess. I talked with my doctor about a year or so ago about anxiety, and I was prescribed medication to help. So when I went to the pharmacy to pick up my prescription, I was confused on, what time do I take this? Do I take this at night before bed? Do I take it in the morning?
Right.
Like, what are the best practices?
And it'll be most helpful. Yeah.
Yeah. And I didn't know. That's a normal pharmacist question. And me working in mental health, I wasn't necessarily uncomfortable having the conversation. But I can understand others might be. So I go to my pharmacist, and my pharmacist, before answering my question, she said, I have been taking this for years. It is so helpful. I'm so glad you're doing this.
Yeah.
And then went on to answer my question. You might take it at night. You may take it. Here's actually how this works. We're looking at blood levels, da-da-da. But that she shared with me that she has anxiety, she has depression, she takes medication for it, and it helps.
Yeah,
like
that human connection to it.
I mean, she basically congratulated me for taking care of myself. And I was like, this is wonderful. So I've shared this story a million times, but it was just so impactful. Even again, for me, who is very comfortable having these conversations, I then turned back and congratulated.
Positive reinforcement, for sure.
Thank you for treating me this way. I hope you do this to everyone. She's like, yes, I do. So good. I think that's wonderful.
Yeah, that's awesome. Yeah, definitely a good example of how to destigmatize that. And, definitely some of that can be cultural or societal. So, in what ways can cultural or societal factors contribute to those feelings of isolation that people that may be experiencing this type of mental health crisis would feel? And how can we promote more of that inclusivity even within our diverse communities?
Yeah, I love this question. So I think when it comes to, isolation, I think we can all imagine having been through a pandemic where there was a time where a lot of us, most of us, were in a sense isolated. We were we had to. And so I know some people thrived in that. Some people didn't, but in the end, I feel like we all now can understand a little bit more what isolation feels like. And that was just physical isolation. So when you think of, being the only person who in the room who might represent your race, or feeling like you're the only person who represents your sexual identity or your culture or your background, you might feel isolated from society or from your community or coworkers for that otherness, I'll say.
Yeah.
So isolation and hopelessness really go hand in hand. And this is where diversity and inclusion in the conversations of understanding cultural competency, that cultural competency extends to mental health. And so perspective taking is just so important in general, but also when it comes to mental health and understanding not just from, race, culture, maybe coming from other parts of the world that we're from, or even other parts of the country, is even within our smaller, familial groups. Yeah. What's the norm? Do we talk about things like this or do we not? And so I think understanding and approaching sensitive topics with not just sensitivity and empathy, but also cultural humility as well. I think that just goes into greater DEI training and why that's just as important as mental health.
Yeah, absolutely. I definitely agree with that cultural humility, cultural sensitivity is very important in public health and in mental health and lots of areas for sure. So one of the things that we kind of touched on much earlier in your experience is developing interventions and what those can play in preventing suicides. So could you tell us a little bit more about that? How can we improve, access to mental health services so that people can get to those resources and we can make sure those people are supported when they're in need?
Yeah. So when it comes to intervention, QPR, mental health first aid, these themselves are designed individual interventions. And so, but that's by way of intervening when someone is experiencing a crisis. The ideal situation would be that they haven't gotten to crisis in the first place, right? And so I'll answer it. Yeah. So to answer that in two ways, I think the improvement we can make for acute suicide prevention is for people to be trained in QPR gatekeeper training, mental health first aid. Again, these are the mental health versions of CPR. It's meant for the layperson to be able to intervene. And then, of course, help them.
I like that analogy.
Yeah, I do too. And actually, going to more on QPR, that was actually the template used to develop that training.
Interesting.
Yeah, so Paul Quinnett in Seattle, Washington, who's a clinical psychiatrist, realized they had the highest rates of people surviving a heart attack that corresponded with having the highest rates of people who were CPR trained. And he thought, wow, what if we had a mental health version of this? And that's actually how QPR was born.
Interesting.
Yeah. So I've always thought that was really cool. And then the improvement we can make in general to improve access to mental health services and support for those in need, that can take on many avenues. So I would say kind of big picture is talk to your state representatives, talk to other decision makers in your community, in your state about mental health needs for your community. Encourage folks to vote for legislation that improves mental health. And then utilize mental health services. So if you think about supply demand, having yourself use and then understand, oh, this helped me, and comfortable with those, again, sort of destigmatization.
Yeah, you can share your experience, and it's
yes. And so, and then finally, really being up to date on any mental health resources for your area of specialty. So, for example, I work in enrollment management in the School of Public Health, so I'm on top of resources for students, for employees. At UAB has what's called a UAB Mental Health Advocate, and so I even have this image on my signature block in my email. So every single email folks get from me, they see this image that links off to mental health resources. And it's a very small example. Yeah, it's a very small example.
The consistency is key.
Yeah, you've got it. You've got it.
So as we'll finish up now, what are some other things you could recommend that, we can all do to bring awareness for especially Suicide Prevention Awareness Month? Or what are some resources that you would recommend, either that you know of in the community or ASPARC or anything like that?
I would say, depending on where you are, if this is an area of interest, volunteer. There's so many opportunities to volunteer as for crisis lines and 988, things like that. But then also see what trainings are available where you work, where you live, where you play, where you worship.
Yeah, UAB has a lot, for instance.
Exactly, yeah. But if there aren't any, ASPARC can help set that up. Whatever your local community crisis center could help set that up. There's also the Department of Mental Health in Alabama. There are a lot of resources out there. And then the resource directory on the ASPARC website is a good place to get started. And then we're here to offer help. A lot of the questions that were fielded from the community is, we've had this happen, or we had this conversation in our prayer group or after work or in our PTA meeting, and we feel like we need to do something. Where do we start? Ask us, and we can help kind of develop a plan and a training program for your group, and we're happy to do that.
Yeah, that's awesome. Thank you for sharing that. And thank you again for joining us today. We know it's a very sensitive and very serious topic. And again, just to everyone listening, we wanted to report again, if you need resources, please seek those resources. Never be afraid to ask for help. And again, that suicide and crisis lifeline is 988. And think about that like 911 for a mental health emergency, just like we said earlier, and please seek that resources. But thank you again for joining us today for Population Health Plug-in. Thank you, Dr. Sullivan, for sharing your experience with our listeners. And everybody, please tune in for another episode of Population Health Plug-in next time.